it was first described in the late 19th century by Hutchinson, okay, way back in 1878. Then in 1889, Besnier described the skin condition, or the one which affects the nose, lupus pernio. And skin biopsies were first done by Boeck. The bone lesions, okay, so at this point of time, nobody had brought them all together. People just described these different things. So bone lesions in sarcoidosis were described in the early 20th century by Kreibich. I hope I'm getting the name correct. And Schaumann, he was the person who put all these things together and said, okay, so this is a syndrome, and he named it sarcoidosis. So it's not surprising because there are so many different findings. It was initially known as Besnier-Boeck-Schaumann disease or syndrome. So what is sarcoidosis? Now our understanding of it is much better. We know it as a systemic disorder of unknown cause that is characterized by non-caseating granulomas with the proliferation of epithelioid cells. So that's the pathology for you. Okay. Now there are other granulomatous conditions. So for example, tuberculosis has caseating granulomas. So this is something which has got non-caseating granulomas. Commonly affects young and middle-aged patients with a slightly higher preponderance for women. Also, it's seen that there are some geographic or certain areas where there's a higher number of sarcoidosis cases. So we do know in literature that African Americans, blacks, much more common. But I'm not sure whether you know that among the Nordic countries, or your Scandinavian countries, Swedes and Danes have a much higher incidence of sarcoidosis. Now, nobody knows for sure whether it's related to, in part at least, to mass screening by these countries or just better pickup rate. If I can say, I do know that when COVID pandemic started, there were some countries who literally, they said they hardly had any cases and definitely no casualties. Now that's, you got to ask whether they actually tested that many. But we know it was a pandemic, and that it'll affect a lot of people. But maybe there's a bit of issue there with, some places they pick up or they diagnose it much more effectively. But from literature, we do know that it's definitely quite common in certain places and in certain people. So what do you expect to see in pathology? Okay, we said already non-caseating granulomas. And we also, the definition in histopathology is these large multinucleated giant cells, an example of which I'll show you. The other way to diagnose is, other than your actual pathology from a specimen, is you have patients who have raised ACE levels. I'm sure you heard of this, but this is a bit of a problematic thing because there are a lot of false negatives. In fact, people say up to 40% false negatives, which is what makes diagnosing sarcoidosis not so easy. Also, you have the CD4 CD8 ratio, which is decreased in blood, and also in CSF studies, it's decreased in sarcoidosis patients. Hypercalcemia is occasionally seen, and it's thought to be due to increased intestinal absorption of calcium, and it results from activation of vitamin D by macrophages in the sarcoid granulomas present in the intestine. So that's an interesting thing. Now, I'm not a pathologist, but from the slide and the description given, I can tell you this thing out there. The big black arrow is what's a multinucleated giant cell, which is characteristic of a lot of granulomas. But along with that, you get surrounding these blue structures, which are your lymphoid cells. Okay. So lymphoblasts, you can see the blue cells. And they've also said in the black areas of collagen, so surrounded by collagen. So it's forming something like a granuloma there. So that's your non-caseating granulomas, characteristic of sarcoid. There are a few syndromes associated with sarcoidosis. One which has been described commonly is Lofgren syndrome. So this is an acute clinical presentation of systemic sarcoidosis, and along with known sarcoid, these patients will have fevers, erythema nodosum, and in particular, polyarticular arthritis. There's a strong predominance for females again, and in the age group of 30. It's interesting to know that these patients have an overall better prognosis with a self-limiting course of the disease. Okay? And they almost always have spontaneous remission. Previously, in some of my cases, I have shown cases of sarcoidosis, and the characteristic chest radiograph uh, finding is that of bilateral hilar and mediastinal adenopathy, which we can see here. So the arrows there point towards both the hilar, right paratracheal node there, and the curved arrow represents an aortopulmonary node. Well, this is called variously by different names. The hilar and mediastinal adenopathy is also called the Garland sign, also called the 1-2-3 sign. And when you have an associated node in the aortopulmonary window, it's called sometimes a 1-2-3 up to 4 sign. Some people have also mentioned pawnbroker sign, which is basically a symbol like this, which is seen outside pawnbrokers. Again, it's basically three, structure which represents three things, which are the symmetrical nodes seen in sarcoidosis. Almost 50 years back, scadding put this staging, and this is an interesting staging, and it's stood the test of time because it has good clinical correlation for patients. So stage 0 is you don't see any radiological abnormalities, although patients would be having sarcoidosis clinically. In stage 1, they'll have lymphadenopathy on chest radiographs. This was basically described at an era when only chest radiographs were available. And this is seen in up to 50% of patients clinically. Stage 2 is when you have both nodes as well as pulmonary infiltrates. So this is the second most common type of presentation and seen in up to 1/3 of cases, or 25 to 30% of cases. Stage 3 is when there's predominantly only pulmonary infiltration and you don't see too much of nodal disease. This is a minority and seen in up to around 10% of cases. And stage 4 is the last one. Okay, and almost 5% of patients progress, or 5% of cases present in this way where they have fibrosis. So just 5% of cases go into that. But fibrosis itself is seen in up to 25% of patients during the course of the disease. Okay, I hope you got that. So 5% at the time of diagnosis and 25% is for overall patients with sarcoidosis who end up going in for fibrosing lung disease. You also have a few other staging which have come through. One is the MERS scoring, which has been put forward by the ILO. Okay, ILO, we do know the ILO has staging for pneumoconiosis, but they also have one for sarcoidosis because it can be a debilitating condition, and patients can seek compensation. So here they've actually divided the chest X-ray shadows into reticulonodular, mass-like lesions, confluent opacities, or fibrosis, and they're scoring. And it's thought that there's better inter-observer agreement with this staging as compared to that of scadding. But the more popular one, of course, is the scadding staging.